your food that has a natural source for your electrolytes. All right? Do I have Tonko and Enid? I can't tell if you're hearing me or not.
Yes.
Tonko and Enid, are you hearing me?
Yes, we can hear you in Tonkawa.
Okay. Enid, are you hearing me? Enid, are you hearing me? That doesn't sound promising. Oh, there we are. Okay, good. All right, so everybody take out your natural source of electrolytes. And I'm going to start here in still water. And I'm going to let some of you tell me what you have. And then tell me what electrolyte. Which of those three would it be a good source for? Some of the things you might have brought may actually have more than one of those three as far as value to the person. All right? All right, so let's start in still water. Give me something you brought and tell me what of those three, potassium, calcium, or magnesium, is it high in? Anybody?
Potato.
Potato is high. High in potassium. Very good. Potato and potassium. That's pretty easy to remember. Somebody else?
Almonds.
Almonds. What are they high in?
Magnesium and calcium.
Very good. So good source. Nuts are a great source of electrolytes. Somebody else in Stillwater?
Avocado.
Avocado being
It's calcium, calcium.
has a little bit of all three. The unfortunate thing about an avocado is it's also high fat. So it's a great thing for those people who are undernourished because you provide both minerals and calories. So again, the idea that Teacher Steve just said, in moderation, they're great. They're healthy on fruit in that respect. Those of you who like things with your guacamole, instead of guacamole with your things, kind of like sodium issues, that's where they run into the problem. All right, somebody else? Cherries and potassium, good. All right, let's go to Tonkwall. Give us some things you got.
Bananas.
Bananas?
Raspberries are high in
What? Bananas are high in what?
potassium.
Potassium, good. Something else?
Grab a bottle of breast milk.
Whoa, that's very naturally occurring. Although it doesn't usually come in a bottled form. So what would that be high in? Calcium, yes. Anything else? All of the above, absolutely. Great source of nutrition for that little tyke. Somebody else?
Raspberries.
Raspberries, what are they high in?
Magnesium.
Very good. Berries, again, are a great source of some of the electrolytes. Anybody else in Tonkwall? All right, let's move to Enid.
Bananas.
Bananas and potatoes.
There are bananas, potatoes, a can of almonds, what do you got? A tomato.
Oh, a tomato. A tomato and pistachio. Tell me about those.
And avocado.
Okay?
What did you guys say?
So what's the tomato and what was the other one?
Potassium is in pistachios.
Pistachios. What were they high in?
Potassium.
She said the avocado was high in potassium.
Yes.
Pistachios.
What was the avocado high? Everything. She said it's perfect food.
It's perfect food. Especially as guacamole. Is that what you're thinking?
Yes.
Some people, I think, actually peel and eat them like a regular fruit. Right?
I like it with salt.
Anybody else? Anybody else in Enid got something different?
We have yogurt for calcium.
Good, good. And a lot of times, cheese and yogurt is higher than actual milk because of the concentration of the over time. Okay, so as you lower the moisture content to make that food more dense, you raise those concentrations. So those are great sources. All right, very good. All right, let's continue on. Let's talk about some meds right quick. We still want to get to our activity. So the first group of meds I want to talk about is modifiers or supplements. Hold on just a second. Okay, so the first one is modifiers or supplements, and what we're talking about there is the different types of electrolytes that we can take as a tablet form or as a liquid supplement. So examples being the two most commonly used would be calcium and potassium, but you can get almost any electrolyte in a tablet form if your physician wishes for you to use it. So we're going to watch the blood levels. If the patient is in a hospital and they're getting daily labs, we can monitor and see what those numbers are doing to make sure it's safe. When would we want to check those levels? Enid?
First thing in the morning,
And in relationship to the medicine?
Before starting.
Yeah, before we administer it. So maybe they were fine, maybe they were low yesterday, we give them one today. We give them one yesterday and now it's scheduled again. We need to check and confirm that we're still okay to give it. Okay, so when would we be able to give it? What would the numbers need to be for us to give it safely?
Are we talking about potassium?
We're talking about any electrolyte in general. When would it be safe to give it?
If it was low.
If it was low, any other time?
If they're actively getting rid of it.
Very good. Any other time? Even when it's normal, but they're at risk for losing it in an excessive amount. Okay? So sometimes we give people potassium supplements when they're on a diuretic, even before they demonstrate having hypokalemia. We're trying to prevent it. Okay? The other nursing implication is if we don't have blood values to look at, we watch for those signs and symptoms. That we're giving them adequate amounts, so the physician doesn't have to prescribe more because it's meeting their need, or that we're giving them too much. So hypo or hyper for each of those electrolytes. The next drug class is the diuretics that we've already mentioned several times. They primarily secrete sodium and water, and they enhance that process, but they can be used in combination with other meds to help lower blood pressure. So we'll see that a little bit more when we have the hypertension lecture in the spring. So there are four main types that I want you to understand. First one being the thiazide type, and it basically enhances the secretion of all of the electrolytes, especially those that I've listed up there, and not just water. Loop diuretics basically do the same thing, just a little bit different process. They affect the kidneys a little bit differently. But the potassium sparing that we mentioned a while ago, the spironolactone, it interferes with what our aldactone does. Okay, so basically it causes the body to retain potassium rather than excrete it. So this is the one type of diuretic that we want the patients to avoid excess potassium intake. So we want them to avoid using things like the salt substitutes that are potassium chloride, for example. Or maybe lost my train of thought. Don't know where it is. We'll leave that one wherever it left. All right, the fourth drug type of diuretic is the osmotic diuretics. These are used almost exclusively in the context of lowering cerebral edema. So these are used in the context of a head injury or maybe a massive bleed, a type of CVA called a hemorrhagic CVA that produces a lot of swelling inside the skull. So osmotic diuretics are used primarily for those kinds of purposes. Now, lest you get bogged down with trying to figure out all of those letters and pluses and minuses, and how am I ever going to remember that slide? Do your comparison and contrast thing. In other words, what are the two problems we're focused on this fall? Fluid and electrolyte, what are the two problems? We're talking about fluid volume, and we're talking about potassium volume. So would that give you a hint? Those are the things you need to know most about those four drugs, is what do they do with the potassium and what do they do with the water? Those other things are not what we're focused on this fall, okay? Simplify your studying. Nursing implications for the diuretics. We need to make sure we're monitoring their labs, specifically those things that might become depleted or become excessive. So their electrolyte levels, as well as what was the lab that allowed us to see their overall electrolyte levels, and what was the lab that allowed us to see their overall fluid status, still water? What were the two we talked about? What part of the CBC? Hematocrit, yeah. Okay. And what's the other one? Part of the metabolic panel. As part of the CMMD, that's a comprehensive metabolic panel, but what's the specific test I mentioned? Osmolality. Okay. Good. Remember, if we don't have labs to work with, we watch for those signs and symptoms that are too much or too little. We give diuretics early in the day to minimize sleep interruptions. Sleep is a vital component of what we need in order to be able to heal and to be able to function well. And these are some things we're going to monitor as part of our ongoing evaluation of their effects. So we're going to monitor their daily weight. Remember we said that weight should change less than a half a pound in 24 hours. If it changes more than that, and they're basically still eating, they're not fasting, they're not in PO, that change in daily weight reflects fluid changes. We're going to monitor their INO. Remember, INO is only as valid as the people are keeping it accurately. So if the nurse and nurse aides are monitoring what they're bringing in as far as water pitcher or as far as trays, and the family's bringing in a big orange slush from Sonic from time to time that we don't really know that even occurred, then all of a sudden our INO can get very skewed. Or if the patient uses the urine hat part of the time, but then, it was too full, so I moved it out of the toilet and just peed in the toilet. Well, then you don't have accurate INO. So daily weight is more reliable than INO when done correctly. So make sure you know how to do a daily weight correctly. Edema. Edema, remember peripheral or pulmonary edema, we're going to look and see, should it be getting better or worse if they're getting a diuretic? Say it real loud, Sherry. Better, that is correct. That it should be going away, because what we're going to do with the diuretic is we're going to remove some of the fluid from the vascular space through diuresis, so they can take some of the fluid from the vascular space and make urine and lose it, okay? They're going to pee, and then the things that are left behind become hyperosmolar, and they're going to pull fluid out of the interstitial space into the vascular space to balance that back out again. That's how we get the fluid out of the interstitial space. That's how we get rid of the edema. It works in the lungs, pulmonary edema. It works in the peripheral tissues, peripheral edema. We got to dry the vascular space out first. Breath sounds. If we're improving the pulmonary edema, then what breath sounds should be going away, Tom Wall? What abnormal breath sounds should be going away? Crackles, that's right. Crackles should become clear if we're getting rid of that pulmonary edema. Skin turgor, what should that do? Enid, I think we're at Enid.
More elasticity back. Can you hear?
It won't stay lifted as long as.
It should, turgor should increase.
Turgor should increase.
What do you mean by increase?
Should have more elasticity. More elasticity. Bounce back.
okay?
Rebound.
In the, as opposed to edema.
Right.
But what I want you to see with skin turgor, remember diuretics are used to get rid of edema. They're not really used to improve skin turgor because there we're talking about somebody who is volume depleted. So if a person who has elastic skin turgor or has peripheral edema begins to develop tinting of the skin, we've gone too far. Now we've depleted the interstitial space and we need to back off of the diuretic, okay? Same way with our mucous membranes. If they become dry, then we've gone too far. And so we're watching for excessive diuresing, not just adequate diuresing. Muscle weakness. What would indicate muscle weakness? What would be the problem that we would be observing, Stillwater? Yeah, too much potassium. So we've depleted their potassium while we're trying to get rid of their water problem. Paresthesia, same thing. We talked about that. So somebody who has hyperkalemia because of their aldactone may start having some paresthesia going on. Irregular pulse. So what's our problem there? We've messed up their electrolytes, specifically potassium. Good. What about their level of consciousness? How does that factor in? Where does that factor in as far as what we're watching for? It's a fluid volume issue, but specifically, it's a fluid volume issue related to that cerebral edema. That's the context of that comment. So somebody who's had a head injury and has all that swelling in the brain, we give them the mannitol, that osmotic diuretic, and their level of consciousness should improve as we pull the excess fluid out of the tissues. Okay. And then thirst. When would somebody get thirsty? If we pull too much, but it can happen when we're pulling the right amount. And here's what I want you to understand. Remember what we said generates our sensation of thirst? It is a change in the osmolality in our blood. So as we give a diuretic, do people get thirsty? Absolutely. What's going to be their most common response to that? They're going to drink more fluid. Are we going to be chasing our tail? Yes. So part of our patient teaching is we have to teach them, don't drink more than you routinely drink just because you feel more thirsty with this little water pill. They have to understand that's part of what's going to have to be experienced to get you better. Okay? If you don't want your feet to look like an elephant's feet, then you're going to have to tolerate a little bit of thirst till we get some of that fluid back off for you. Okay? All right, health promotion. Health promotion is what we're talking about when we talk about people who don't yet have a fluid electrolyte problem. We're talking about people who are basically doing just fine, maintaining homeostasis, and we're trying to prevent them from developing a problem. So these are things we can teach healthy people or people who are recovering from a fluid electrolyte problem so they don't develop it again. So the first one is make sure they're drinking 2 to 3 liters of fluid a day, preferably milk and dairy products because they are potassium and calcium and magnesium rich. They are a great source. Not just breast milk. Human milk is not the only milk that contains those things. So does dairy products, dairy milk. Okay, and we said alcohol is a diuretic, a mild diuretic, so limit or avoid it to minimize your disruption of your fluid electrolytes. Eat a balanced diet so you're getting all of those different types of electrolytes in adequate amounts. Remember, if your kidney function and heart function is good, your body can deal with excess. It cannot generate inadequacies. It can't solve those without what you eat. Make sure you maintain normal weight because of its impact on your fluid status. Remember what type of tissue is better hydrated? Muscle mass, yes. Increase fluid intake with strenuous activity and high temperatures because as you use those muscles, you generate more body heat and you lose more fluid electrolytes. So sometimes during strenuous work or strenuous activity, playtime if you will, you need something like Powerade or Gatorade or some of those electrolyte enhanced drinks to supplement what you're losing. Recognize there are things that happen that can lead to those imbalances, and make sure your patients know when to recognize those as well. Monitor for those things that they may not be diuretics, but they do have effects either on the kidney or the heart, and as a result may impact fluid electrolytes. Teach your patients when they need to see their providers, okay, especially those who have cardiac or renal problems. When do they need to go talk to their doctor and get an appointment? So I've listed some of those common signs and symptoms there for you. If they're taking care of someone who is at a high risk or is completely dependent upon them to meet their need, teach them how to monitor that individual's INO, and teach them how to check their weight appropriately on a daily or weekly basis. Teach them how to recognize signs and symptoms of problems, so they'll know when to notify the doctor for that individual. Teach them how to maintain. So recognize some people in today's healthcare environment may have tube feedings or IV fluid intake even in a home environment. So teach them how to watch for fluid electrolyte problems in the context of what their situation might be. Teach those individuals who are at risk for hypovolemia, teach them how to make those slow position changes so as not to stand up and fall down. Elevate feet or head of bed. That sounds contradictory, so let's see, I think I'm at Enid. Why would I say one or the other? What's the context for each of those?
Swelling in the lower half and elevate the feet to have fluid.
Okay.
Basically.
CHF.
When would we elevate the head of the bed?
CHF, someone said,
Respiratory problems?
respiratory problems.
Okay, so if somebody has pulmonary edema, we'd elevate the head of the bed. If they have peripheral edema, we might elevate the feet in order to help promote the reabsorption of that fluid back into the lymph system, and out of that interstitial space back into vascular space. Why would we use turning frequently? What's the significance of that? Still water? I think we're still water. What's the significance of that in the context of fluid electrolyte?
To drain pulmonary edema.
So it's not for like pressure voltage, you're talking fluid electrolyte.
It's fluid electrolytes. Now, I didn't say it didn't have to do with pressure ulcers.
Pressure ulcers.
How? How does it factor into a pressure ulcer?
Increase points of pressure by moving around and increase circulation.
Okay, remember we said in the circulation lecture that excess fluid can cause a constriction problem. Okay, so constriction from excess interstitial fluid, so excess edema, can limit blood flow to those tissues. So by turning those patients, you're shifting where that interstitial fluid travels. And so whatever part of their body is laying on the bed will have the greatest amount of edema. We call that dependent edema. So if they're sitting upright, it's going to be in their feet and their lower legs. If they're sitting in a reclining chair, it's going to be in their hips and their buttocks, maybe their tailbone. If they're laying in bed, it's going to be on whatever side they're laying on, left or right, or whatever it may be. Okay, so turning them is going to shift that fluid to promote circulation.
What about gravity?
Gravity? That is gravity. We are talking about gravity. Absolutely. Okay, make sure your patients know about their medications, including the side effects to watch for. And then sometimes we need to have referrals. Sometimes we need home health nurses going out and checking on these people, monitoring their status, monitoring their situation. Sometimes we have additional resources in the community that are necessary that families and patients might not know about. Like, where do you get an IV pump? Where do you get a tube feeding machine? Where do you get a lift to help somebody who has a fluid volume overload problem and you can't even get them in and out of bed? Where do you get those things? So helping them to know where to pick those things up, okay? And then sources of information are always useful as well, both online as well as paper. Culture and spirituality, when we're talking about culture and spirituality, we're talking about how that impacts a fluid electrolyte problem. So Native Americans, there are certain tribes who use sweat lodges as part of their spiritual experiences. And as a result, they can very easily get into a hypovolemic or an electrolyte problem. Fasting may be due to also to a spiritual discipline. So people who are not Native American may still use fasting as part of their worship process. And again, can deplete their fluid and electrolyte status. Fasting can be very dangerous for an individual who has a cardiovascular or renal problem already. Some cultures may avoid specific food or drink during times of illness, and I mentioned that before, that where possible, we want to honor those persons' personal preferences. On this slide, I've listed some alternative things. So we can encourage and help patients make dietary changes to either increase or decrease certain electrolytes. So maybe they're on a sodium-restricted diet. Maybe they're on a potassium-restricted diet because they do have kidney problems. Maybe they're on a magnesium or calcium-restricted or calcium-enhanced diet. Dandelions. For those of you who like to go out and eat dandelions, be aware that that's why you're going to the bathroom so much, because they also have a form of diuretic. No, really, people eat dandelions as part of their salads. I've never heard of people eating the root of a dandelion, but the leaf apparently has some good flavor to it. The flower tastes good? Do you eat it when it's fuzzy, or do you eat it when it's yellow? Okay, sorry. That was a sideline. Sorry about that, guys. Licorice can also promote potassium loss. And then I mentioned this earlier, a lot of the common salt substitutes that we recommend for people who are on a sodium-restricted diet can contain potassium as an alternative to the sodium. That's okay as long as that patient doesn't have heart failure accompanied with renal failure. Otherwise, they could get into that hyperkalemic problem. Or as long as they're not taking what type of diuretic?
Potassium sparing.
Potassium sparing, very good, the spironolactone. As far as delegation, remember whatever objective data can be gathered by a nurse aide based on their knowledge and skill, we can delegate that to them, but it's the nurse who monitors those trends. It's the nurse who determines whether the patient is maintaining homeostasis or getting into problems. And then it's the nurse who's responsible for teaching the patient on that initial approach to things. All right? All right, any questions about any of that? All right, during these next few minutes, I'm going to give you, I'll give you to 10 after. Very quickly, do page 1 of page 261. So highlight and identify the 4 nursing problems that we've talked about. And when you are done, I want the instructors on all the sites to look at those real quick for me to see that they have been completed. So I'll give you a few minutes to do that with. This is our
Oh, that's blurry.
Yep, I know, it's not right today. All right, if you can tell what that says. If I get it where you can see it, you can't see it all. So, for whatever reason, it's all messed up again. So I can't change it. So, there you go. If that makes any of you nauseated, sorry. Hopefully you won't mess up your full life. You have to have sound effects to do this, right? Lost it.
So the ones we go over hypovolemia.
No, I can't leave it up there long enough because I want to do that.
Yeah,
So would that be for
All right, there you go.
Can we see the bottom?
Miss Betty, can you mute Enid's mic? We didn't get half of that because we can see Enid.
I actually had to ask him a question though.
Oh, so do we have to do the repeat?
Wait a second, I
Oh.
have a question before. Can you?
All right, so mute the student mic real quick, and then just me talk. So talk to me, Enid students, so I can see if you're muted. You're muted? Okay. All right. Now does everybody see it? So this is Conquest's chance of getting nauseated. Here we go. You gotta read backwards.
Mr. Byron Weedle, I appreciated if you just read us the answers.
Oh, man, you guys are so demanding. What is that? Oh, okay. All right. Dry mucous membranes, hypertension, jugular vein distension, muscle twitching, dizziness, positive tilt test, asystole, diarrhea, edema, vomiting, bradycardia, decreased skin turgor, nausea, irregular pulse, cramping, confusion, muscle weakness, bounding pulse, crackles, lightheadedness, fever, half-pound weight gain in 24 hours. Greater than half-pound weight gain. All right. So I don't know how well this is going to work either because I can't make it smaller. I don't know why it will not focus when I make it smaller. Oh, maybe this down here.
It is.
And for accidentally decided to hyper,
So frustrating.
This is unplanned weight loss. It says weight loss.
you never planned to.
Well. How can I do this? I don't have those with me and we're all but out of time. So,
Oh, what did you miss?
well,
Weights are staying
I do not have a way to make that smaller for you guys. All right, so turn to page 262 then and complete that one. So on those scenarios, you'll just have to do the first ones by yourself, and then I'll walk through as many as I can on study session. Sorry.